Welcome to today's session. In the session today, we are going to learn about role of emergency medicine and role of emergency medicine specialist in the hospital. We need to first understand what is an emergency medicine department first. As you know, world over there are various terminologies for managing emergencies. There are casualty departments, there is emergency room, and there is an emergency department. So what is the difference between these three? A casualty is a place where patients are getting treated, but clearly there are no defined structure or process. Whereas in an emergency room, there is a structure and process. However, the care is delivered by non-emergency specialists. Whereas in an emergency department, clearly there is an existing structure and process, and the care is expected to be delivered by a trained emergency medicine specialist like you. Why is it important? Once you have a trained emergency medicine specialist, that will result in better clinical outcomes. That's why setting up and establishing emergency departments becomes very, very important. Let's look at a scenario of emergency medicine in India. Currently, if you look the overall context of emergency care in India, you could say more than 40% of the entire emergencies in India is still managed in casualty departments. This is clearly because of lack of availability of such structure and also qualified and trained emergency medicine specialists. And that is where you and me come in so that we can provide those structured emergency care for our patients. We roughly have about 20% of our hospitals in this country with emergency rooms, and only about 10% have got a set emergency department where clearly there are emergency specialists who are working. And there are many hospitals and many places where we don't even have a basic casualty or an emergency department to manage critical cases or emergency cases. In 2019, WHO emphasized that emergency care is the first point of contact with the health system for many people, and it gives definitive care for all those who need. And WHO was ready to support countries to provide this high quality emergency care as a part of a journey towards health for all. This emphasizes the need and importance of emergency medicine, emergency care, and emergency specialists across our country. So, what is an emergency department now? Why is it important? Clearly, emergency department is a primary access point for hospital. Like the outpatient departments, emergency departments are the key area where patients will come to an hospital. And basically, this is the face of a hospital. What do I mean by face of a hospital? The quality of care delivered in an emergency medicine department is extremely important because as a patient and as a patient relative, they tend to take the impression of this entire hospital and its quality of clinical services based on the first impression which they get. That's why emergency medicine is extremely important, emergency departments, because they are technically the face of the hospital. So whatever we do in an emergency department, in an emergency context, clearly reflects on the quality of the hospital and the quality of care the hospital is going to deliver for the future. So it's very, very important. And clearly, as we all know, we save most lives and we manage all critically ill patients, differentiated and undifferentiated cases. Also, this is the department where you tend to see a lot of potential violence or violent situations which may arise. And also a department where a lot of life-saving and critical procedures are being conducted in, I would say, a much more open setup rather than in a closed setup. For example, you might be doing an intubation where you actually have 10 to 15 people around the patient compared to an elective intubation which is typically done in an operation theatre. So it's clearly a high stress and highly noted department in some of those contexts. Who is an emergency physician? An emergency physician is a doctor who has been trained to engage in immediate initial recognition, evaluation, and disposition of patients with acute illness or injury. This is the definition provided by American College of Emergency Physicians. In this training program, you will actually learn how to manage these three parts so that you as a doctor can provide best emergency care. If you look at this definition, it basically talks about three core components: assessment, evaluation, recognition, evaluation, and disposition. So there is a certain structure to or process to evaluate or recognize a sick patient. Simply triage, as most of you have heard this name. And then how do you evaluate? That's where basically your clinical acumen, knowledge, examination, evaluation comes in. And then eventually you need to take a call on whether you're going to admit these patients, discharge these patients, and what sort of a care you're going to provide. So these are the three core components of an emergency specialist. And as an emergency medicine doctor, you should be well versed in all these three. So what is the role of an EP? As you can see in the slide here, first and foremost is to assess any patient who comes to the emergency department. So you got to define the criticality of the situation so that each of them get a limited, clear, time-bound care. Once you have assessed them, then you decide on what's the course of treatment. And as an emergency medicine specialist, we deliver that care and treatment. And then at the end of the treatment, we decide on the disposition. This is the core concept of managing these patients. But clearly, while doing so, we also have to keep certain parameters in our mind. One is around quality of care delivered. Are we sticking to the right protocols? Are we following evidence-based practice in medicine? Safety is another important aspect. Am I clearly following, say, infection control preventions? Am I using adequate PPE? Right? So these were some of the safety concerns. And clearly we need to look at outcome parameters also. And many of the outcome parameters are time-bound. So for example, am I delivering thrombolysis within the defined protocol time, right? So that I can get a better clinical outcome. Am I moving a patient quickly to a cath lab for an advanced procedure so that the clinical outcome is better? So these were some of the key areas in this process of assessment, decision, and treating a patient. Apart from that, as an emergency physician, we have also got a role in three other areas. One is around cost, other one is around looking at revenue for the hospital, and the third one is around customer satisfaction. So we need to also look at how do we deliver this exceptional care by keeping the cost as low as possible for the patient who has come in, and also ensure both the patients as well as the relatives are clearly communicated about what we are delivering to these patients, because that's key for better customer satisfaction or patient satisfaction, right? Because in today's world, most of the hospitals clearly expect the hospitals or the emergency departments to provide best of that patient experience and satisfaction along with the clinical care, which is also important. So we as an emergency medicine specialist and emergency department, as I told you, we are the face of the hospital. We need to ensure that customer satisfaction is one of the key focus areas for us. What is our approach to a patient? How do we now assess and how do we now decide? As you can see, we need to be well versed with concepts of triage. You will also learn about triage in this training program. Triage in simple terms, it's basically to segregate patients at different levels or to different levels to see who deserves urgent and immediate care and who is the patient who can actually wait a little bit in the emergency room because they can wait. But there are some patients who clearly can't wait because the more you wait, the outcomes are going to suffer. Right? So these are the patients whom you will see first. So that's a basic concept of triage. You're going to do a focus assessment and stabilize ABC. What is ABC? Airway, breathing, circulation. You'll be hearing this ABC throughout this entire course in many of those lectures. Airway, breathing, circulation remains the key focus area for any emergency medicine specialist, irrespective of type of emergency you handle. What is a focused assessment? Focused assessment is clearly towards a history. Usually in an emergency department, you get to see medical emergencies, trauma emergencies, pediatric emergencies. The assessment for all these three varies slightly different from what traditionally we have been taught in terms of getting a chief complaint, past illness, present illness, and general systemic examinations. While these are extremely important, still, the order in which you do and what you try to implement first slightly varies. For example, in a core emergency situation, let's take an example of a trauma or even in a medical emergency, you would actually focus on resuscitating the patient first, stabilizing airway, breathing, circulation first, before even moving to history. Right? So this order or in the manner in which you approach a patient differs in an emergency context compared to a regular, say, an outpatient context or a regular a non-emergency critical care context. Right? Clearly, we as an emergency medicine doctors have to form a differential diagnosis based on whatever information we have got. Many a times, as you know, we get a lot of undifferentiated patients. This could be the first time for them in our emergency department. Sometimes there are no attenders or relatives, no clear past medical history or previous medication history is available. Patient perhaps are in unconscious, unresponsive state. So the information which you get sometimes may be very, very limited about the clinical condition. So we got to make the best of differential diagnosis to treat some of these patients. And once you have taken the decision, clearly you investigate accordingly. So it could be radiological diagnostic investigations. And of course, history is very, very important. And sometimes we may not be able to actually get an history because either the patient is in a condition where he's not able to provide a history or there are no attenders, right? So sometimes you don't have to wait for the history. You got to straight away start providing that resuscitation and stabilize the patient first. In simple terms, what is different in an emergency medicine department or how an emergency physician manage is basically action first, stabilize first before we go on to history. And this is in an acute critical situation, I mean, right? Okay. And what is unique about emergency physician doctors? What is expected of you and me as an emergency physician? To be comfortable with unknown. Because many a times, as I said, you won't get a full detailed history. You won't be able to get an opportunity to review all the entire files. These are not patients whom they are following up with you for a longer time. This is the first interaction you are having with many of these patients. So clearly, you are facing a lot of unknown situation there. Unknown situation, unknown things there. And we need to get comfortable with facing that unknown. We'll get to see a lot of undifferentiated patients. Very similar looking history. Right? Elderly patients. These are very undifferentiated patients, so you need to be comfortable managing them. And as you know, emergency medicine department is clearly where teamwork plays a very important role in terms of bringing in the best of clinical outcomes. We'll be working alongside with your senior colleagues, junior colleagues, and our nurses. And this is one of the few departments where clearly there is no hierarchy structure where the information flows from top to down. It's not that the senior most doctor gives directions and just simply follow. If you actually look at a good emergency department, you see all those people, all the team members working together at the same time, where there's a multiple cross information and horizontal communication happening in the best interest of the patient. So that's what we call it as hierarchy flat and team based. Right? Look at a resuscitation scenario. Clearly, you got 3 or 4 people working together, communicating with each other constantly to provide or to discuss what's the next step for the patient. Right? So I think that's why emergency medicine is typically a team-based specialty. And of course, with a constant eye towards efficiency, quality, and outcome. Right? And clearly, emergency physicians are extroverts on demand. What I mean by that is like when your patient, for example, needs an advanced care or has to be seen by an advanced specialist, we are the people who actually get those specialists to come and have a look, right? And sometimes if you're not able to get those specialists to come and have a look, we actually fight for our patients to get those specialists to come and have a look. That's what I mean by extroverts on demand, and we need to be extroverts on demand to get the best clinical outcomes for our patients. And of course, many a times we don't get the appreciation for saving the life of a patient, but that's okay. So we are not here to get only appreciations. Our primary role and responsibility is to ensure our patients' lives are saved. Let me take through a quick scenario, and also that will tell you what is expected of us as emergency doctors in emergency rooms. Look at this scenario. You got an young male with a road traffic accident, clearly a polytrauma, and this ambulance emergency medical service personnel calls you as he has gone for a pickup from the scene, saying that, hello doctor, I got a patient here, clear case of an RTA, we are bringing him to the hospital, right? But he's clearly has got an oral bleed. He's breathing okay now, but we see only saturation of 86%. Air entry seems to be fine, but he's breathing fast. His respiratory rate is about 34. He's slightly tachycardic, it's about 140. His blood pressure is slightly around the low normal side, I would say about 98, 60. His consciousness level is reasonably okay. It's about E2, V3 and M5. And this patient has also got an orbital swelling. He's got a left leg deformity. and there's an open fracture which is bleeding from. This is the scenario we have encountered, and this is the patient currently in front of us whom we are bringing to the hospital. Think about it for a second. When such a call comes to you, what is expected of us and what do you do? Clearly, as emergency physicians, we got certain responsibilities in managing or guiding pre-hospital care services also in stabilizing these patients. In this scenario, I'm pretty sure most of us would advise airway breathing circulation. So ensure you start protecting the airway, maybe start supplementing oxygen, and also ensure that the bleeding is controlled by compression. Right? These were some of the simple advices I'm sure all of us would give, and this is exactly what is expected of us in pre-hospital care setting. So what's the role of emergency physician in EMS setting? Create and train emergency medicine response teams, pre-hospital care teams, limiting disability before a patient actually comes in. So whenever we get a call of such a patient, give telephonic advices on how do we now stabilize ABC to a reasonable extent until the patient reaches the hospital. Provide safe transport, and we also prepare our receiving unit to handle such a case. For example, in this scenario, we clearly know this is a high velocity road traffic accident. That means clearly your resuscitation room and all your teams and members have to be ready to receive this patient to provide resuscitation. And we need to alert concerned specialty and definitive care specialty. For example, in this case, clearly there's a possibility a neurosurgeon needs to be involved, an orthopedician needs to be involved, and maybe even a general surgeon. All of them have to be put on high alert. This is extremely important for us. In some case of a medical emergency, for example, right? So if it's a clear case of acute myocardial infarction, we may even give advices to start thrombolizing while the patient is being transported. That's what is called ambulysis, right? So based on the scenario, road traffic accidents, trauma cases, poisoning cases, medical emergencies, we need to give those advices and manage pre-hospital care scenarios. Once this patient has reached the emergency, assuming this is what you are seeing, this is a patient who has got oral bleed. Clearly the EMS team, based on your advice, have put the patient on a cervical collar. Patient is still tachypneic, breathing now at 45. His saturation is around 85, and based on your advice, they have started oxygen outside, but in spite of 15 liters high flow oxygen, the saturation is only 84%. And clearly this patient doesn't have air entry at the right side when you examine, once you have received him into the ER. The blood pressure has fallen compared to the first reading what the EMS personnel has told you. The heart rate is further shot up. His sensorium level has clearly decreased. It's E1, V1, M5, right? And clearly his right leg, based on your advice, they have controlled the bleeding, they put a compression bandage. You also notice that there is an abrasion on the right upper quadrant of the abdomen and left periorbital swelling. Right? So what are you dealing here? You're clearly dealing with somebody who has got an airway compromise, who has got a breathing issue, you've got a circulatory system collapse. Clearly the patient is bleeding somewhere. It's an external bleed or internal bleed, you are yet to determine. You've got to stabilize his airway. He has lost his sensorium. That means there has to be advanced airway in place. There are quite a few things which is running in our mind. And that's exactly what we would do. So what would happen if it's a well-set emergency department where there are clear set systems, clear processes, and a doctor like you who is well trained in emergencies handling the situation, right? What would happen? Clearly, you will look at intubating this patient, airway breathing circulation as we mentioned earlier. If necessary, you might even go for advanced airway procedures. If there's a difficult intubation, you can go for a crico or a tracheostomy based on your training, right? And if this patient has got air leak or bleeding, clearly ICD is something, intracostal drainage is something which you will provide, right? If it's a medical emergency, like an inferior wall MI with heart block, complete heart block, you might think about even pacing, right? What else an emergency physician can do? Clearly place central lines, arterial lines if needed, pericardiocentesis if needed, gastric lavage in case of poisoning, right? Suprapubic catheterization, reduction of fractures. This is some of the procedures the patients will actually require and some of the skill sets as emergency medicine doctors we need to have. And as a part of this training program, we will also be training you in some of these skill sets when you come in for a skill training program in person. What are the other skills which I would require? Let's take this trauma scenario. I mentioned that there is an abrasion on the right side of the abdomen. What it could be? It could be an underlying, intra-abdominal solid organ injury, like liver laceration, possible. How do you assess this? We need to have this basic skill of doing an ultrasound, We call it as fast focus assessment sonography in trauma. So as an emergency physician, it's expected that you have some skills around doing an ultrasonography, echocardiography, reading ECGs, ABGs. This patient has got a head injury, so that means you need to do a CT scan or an MRI scan. In a trauma, clearly probably a CT scan. And you will be able to read, or you should be able to read that CT scan. So imaging and reading those imaging, X-rays, and also reporting those X-rays. And once you have established advanced airway, connecting these patients to a ventilator. Or in case if it's a cardiac emergency, cardiac medical emergency scenario, maybe pacing, maybe defibrillation in case of cardiac arrest. So these are varied level of skill sets we as emergency medicine specialists should clearly learn, practice, and have confidence in delivering. As a part of this training program and skill, you will also learn how to read those images, X-rays, CTs, and also perform some of those basic ultrasounds. So, as I mentioned earlier, what's our role as an emergency physician while we assess, decide, treat and dispose this patient while keeping outcomes, quality and safety as the key parameters, also mindful of cost, customer satisfaction, right? There is another important factor to this, which is the time frame. So clearly, all of this have to be done in a very set, limited, predefined time frame for each of those patients, right? You cannot delay care in any situation because emergency department is not that you're going to only manage one patient at a time. You're going to have similar patients. Imagine I gave you a scenario of this RTA. Also, we spoke about some scenarios or context, what happens in a cardiac emergency. Assuming in your emergency department, you got 4 or 5 patients at the same time, one with an RTA who's bleeding, one with a cardiac emergency, one perhaps with consumption of poisoning, right? So you got varied patients, one perhaps with a seizure or maybe a stroke. So you got to manage all these situations at clear time frames and together. I think that's where the biggest challenge lies for emergency specialists, and that's exactly what we need to prepare ourselves for. Looking at this scenario, look at this image here, right? What are we trying to do here? Don't take this image as we trying to replace any of those specialists. All those specialists are extremely important. They are highly skilled and trained in their own field. What we are trying to do here is basically we are only substituting the first 10 or 15 minutes of the time of all these specialists by we taking that responsibility of providing that care. That's what this actually says, right? We kind of help all the specialists in this trauma scenario. For example, this is a patient with head injury, chest injury, intra-abdominal injury, and also a fractured femur. That's a scenario we saw. So clearly, these are 4 or 5 specialists has to eventually manage him in the due course of time. But you can't wait for all 4 and 5 to come and deliver or come and only manage their part of the current situation. You as an emergency physician should be able to comfortably resuscitate and stabilize and provide that care on behalf of all the specialists until you give them that time to prepare and then come and take over this patient. That's why the role of an emergency physician is extremely important in any hospital setting. So what happens if there is no emergency department or an emergency specialist? We all know. So clearly your quality, outcome, safety, cost, customer satisfaction, everything goes out for a toss. So that's why emergency medicine department needs to be there in all hospitals and managed by emergency specialists. And some of the outcomes, if you don't have a proper emergency department or specialist managing, so violence, right, and people are agitated, they're not informed. So these are some of the risks if you don't have a clear set process or protocols. So what are our roles in rapid response teams as emergency specialists? We also have a role inside the hospital to create and train rapid response teams. So any resuscitation which happens in the hospital or which needs to be done in a hospital context, we are the people who provide that response. Code blue teams in some of the hospitals it's called. Various codes in the hospital. Sometimes it's a disaster. Sometimes it's cardiac arrest scenarios. We also have a significant role to play in managing mass and multiple casualty incidences in hospital context. Disaster response, whenever there is an external disaster or internal disaster. So we need to train ourselves and also the teams on managing and responding to some of these critical situations. Apart from all those key clinical skills, there are a few other responsibilities of emergency physicians. Right? Clearly, we need to train and also manage emergency medical services, pre-hospital care systems, guide pre-hospital care systems, provide resuscitation, that's a core clinical skill, learn to teach and train our colleagues, friends, nurses, and junior colleagues in managing these patients. Clearly, we need to liaise with both other doctors, administrators, external people, sometimes even with law enforcement authorities, as we might manage medico-legal cases. We should be well versed in terms of managing any codes within the organization, like Code Blue, Code Disaster, etc. Right? And also lead emergency medicine specialist and specialty. So these were some of the key responsibilities. So, does having an emergency department improves outcome? Clearly, yes. Multiple evidences on early triage, creating focus, early resuscitation, decision-making, team approach, clearly having an identified person responsible for care, great collaboration between EPs, trauma surgeons, other specialists have definitely led to better clinical outcomes. There are various studies we have proven that once we have a trained and qualified emergency medicine doctor like you, who has upgraded his skills to deliver best of emergency care, the clinical outcomes are always going to be better, and which will also lead to less violence. So with this, we have come to the end of the session. Thank you so much.